This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.
Welcome to today's meeting of the Health Committee. Members of the public may like to follow at London Assembly on social media and use the hashtag AssemblyHealth for this meeting. Please may I remind participants to silence your devices. The main item on the agenda is men's mental health in London. However, we have a few short items of business first. Can I now ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chairman. No apologies have been received today.
Thank you. Moving on to declarations of interest. Can we note the list of offices held by Assembly members?
Noted.
And can I ask members if they have any disclosable pecuniary interests in any specific items listed on today's agenda?
No.
Perfect. Thank you. On to the minutes. Can we please confirm the minutes of the meeting held on the 2nd of June 2025? Thank you. Summary list of actions. Can we note the completed and outstanding actions arising from previous meetings of the committee and the additional correspondence sent and received?
Noted.
Thank you very much. Response to committee outputs. Can I ask the committee to note the response from the Parliamentary Under-Secretary of State for Public Health and Prevention, Department of Health and Social Care, to the committee's Getting to Zero by 2030 HIV in London report? Brilliant, thank you. Now we are on to the main item of business for today. Before we begin our discussion, we'd like to note that some of the content may be triggering or difficult for listeners. We therefore would like to urge anyone who may be affected to seek help, for instance through the Samaritans or Mind, who offer 24-hour help and support. I'd now like to extend a warm welcome to our first panel of guests joining us to discuss men's mental health. We have Sean, Ian and Chris. Thank you so much for being here with us today, guys. We really appreciate you taking out your time to speak to us and give us your valuable insight. So the first question really, I don't want to so much as ask you this question as almost just give you the floor as to what you would like to say or open, or you would like policymakers here to know about your experience or perhaps your views. So I'll give you, an open, no questions forum and platform here. So I'll start, Sean, perhaps with you.
Thank you, Chair. Well, what came to fruition was the house burning down when I was young. And we spoke on the meeting of the 25th about how men tend to seek out support only when that is the case. So for me, I think getting help seeking, those first encounters are a very important thing to get right. So that's both once a person has made contact and also getting the person to make that contact. So I would like to speak about both. Firstly, getting somebody to make that contact, I think that there's a lot of stigma attached to mental health, especially for those people who are experiencing it for the first time and who haven't developed coping mechanisms. And when it's a matter of getting that help, it's like, well, who do I go to? My first impression was that, if I go to the GP, is it going to be a 10-minute appointment? I thought, well, what can that really mean? That's likely to mean coercion. That's likely to mean medication. Are these things that I really want? And so the biggest way in which I could have my say felt like was to not seek out that support when it would have been really helpful to before that fire started. So then I think I would make some suggestions on that, but maybe if I just focus on the problems to begin with. So once inside the system, it is an honour for people to be able to treat somebody with mental health. I think that should be really the position that all those who are in that privileged position take, and that it is really easy to look through a medical gaze at people and ignore personalities and that type of thing. But these are very, very important. It can seem like nasal gazing on the patient, just self-interested, not seeing the bigger picture. But how do we take those steps towards a situation in which the person's identity is respected and their needs are met. So, like, for me, the information that needs to be put out there, which has been put out there, needs to start in schools. People need to be informed about the way the system operates, and we need to do better than information giving. You know, so we need to do better than coercion. We need to do better than information giving. We need to go all up those steps in the ladder, all the way to co-production on this. And so, lastly, just to say about the way things could be better, it would be if, and there's a cost to mental health services, so let's put that out there, that if there was more like having a conversation with people, so if there was a realm in which people could operate, which was not private but not public, that was sort of an intermediary where there's lots of peer support available to people, where they could talk in that, oh, I 100% get what you mean, sort of like attitude, rather than like the dichotomy of the positions of power that exist in the relationships in which I discussed.
Thanks, Sean. Ian, did you come in?
I don't know how to follow that really, Sean, because you've said an awful lot of really important things. I think that certainly I'd like to get over the point that I've been suffering from mental health issues for 50 years, and 50 years ago there was basically no help, no understanding. And in a sense, the first primary port of call for most people, even today, is their GP. And I think listening to some of the things that we've been discussing, a GP is not necessarily the best port of initial call, because they are general practitioners. In a lot of cases, they're there to fight fires. They don't have time to look at things holistically. So, I mean, a great case in point, I mean, having been at the same surgery for over 50 years, being treated on and off for these issues, it's only very, very recently that I was put in touch with the local social prescriber, because the doctor just hadn't had the time to suggest it, and everyone else thought, well, you must be involved with that process. So I have actually improved my mental well-being in the last few weeks just because I've been put in touch with Mind. I'm meeting peers, and sometimes, you know, the first port of call might well be somebody who's actually had their own experiences of mental health issues. I mean, immediately I met these two guys. We had that shared experience, and we're very, very good, people with mental health issues, at understanding each other and patting each other on the back and saying, you know, these are my experiences. And if you've got somebody on the other side of the counter, if you like, a doctor, a GP or whatever, who hasn't had first-hand experience, they're just, you know, the idea of an authority figure looking down on you, that's sometimes how it can come across. I was shocked to learn how few men actually do take advantage of mental health services. You know, if it is 1 in 10 or 2 in 10. I actually looked at the drop-in group that I'm a part of on a Monday, and it's absolutely right. Where are the men? And I don't know whether that's got an ethnic slant or whether it's got, you know, men are just poor at approaching, or just aren't even aware of where to go for help without feeling stupid or whatever. I mean, me personally, it's never been an issue. I've always been able to talk frankly and openly, even when I was hospitalised, which I have been, about my condition, because to me it's part and parcel of who I am as a person. So I don't sort of resist it. It's just that whenever I have relapses or issues, it's the same old questions, the same old firefighting. There's no sort of overall holistic treatment view, certainly in my experience of coming from West London, and it seems to be the same elsewhere. Local funding streams, which mean I can go to Mind in Kingston and do a drop-in any time, whereas in Richmond, Mind don't supply that, even though Richmond are particularly well funded and are very, very proactive with social services. They're brilliant. But the fact that there is this postcode lottery, even within the health service areas, the fact that the boundaries are different, the fact that health authorities, can't offer the same services. In Hounslow, next door, I was told by the social prescriber there's about 50% less access to things that would make anyone's life better if they're suffering from mental health issues. There is this lottery about where you live. And all these things it seems very sad in the 21st century that there isn't an overview. There isn't a combination of health service, council, funding streams. This may be something that you might have a hand in advising on, I don't know, but it just seems so bitty. I mean, it's one of the major problems of the 21st century, mental health issues, and yet it just doesn't seem to be, I don't know, it just doesn't seem to be any overview, joining up with the dots, all the services working together rather than separately. And I mean, in a sense, that's pretty much what I'd like to say. I hope that's of some use.
Thanks, Ian. Chris?
Just thinking about, just reflecting on the point about men don't look for help until the fire's burning. And I think that is partly from a society that, from the Industrial Revolution onwards, everything has to be normalised and everyone is normal. And men especially don't want to be out of normal. We're part of the pack, wolf pack. And I see in society that is increasingly talk about diversity, with special needs and with sexual diversity, sex diversity. But I think looking at neurodiversity is really slow. And I think that is something that just isn't looked at properly. Okay, everyone's now talking about ADHD, but ADHD is a part of a constellation of ADHD, autism, dyspraxia, dyslexia, Tourette's, tics, and they're all part of neurodiversity. Though I wonder if anyone is actually neurotypical completely, but I think it's important that that culture is not pushed, or celebrated, that we're all different. And I think if that is celebrated more, people are more likely to come forward because they're not going to feel like they're different from everybody else. Everybody is different. And I think that's really critical. Looking at the gateway I think the GP is a really bad gateway. It's a really bad gateway for mental health. I think, in 100 years' time, we'll look back and think, what on earth is going on with that? And partly because the GP isn't trained, or there might be one GP. My practice, where I went, was a big one. It was like 30, I don't know, it's a big practice. And I finally saw one GP that had some mental health training, and the difference was enormous. But it was a lottery that I got her. It kind of been so many times. I found her eventually, but on the first visits, it wasn't there. And as you say, that it's a prescribing place. And I also really doubt the accuracy or the knowledge of the prescribing. I was put into a system and went through SLAM eventually, through the NHS after a lot of triaging. But I was seen by a trainee GP at that service who reported into psychiatrists. I eventually, because I had a major depressive disorder, after several months, I went to pay for a psychiatrist who was actually part of SLAM. So I paid for him privately, and the advice I got there was completely different to the advice I got from the doctor. I worry that the advice on that, so number one, it prescribes, and number two, I'm not sure that it prescribes with any accuracy or with any diligence. And I think that's partly because of the neurodiversity angle. I think you have to put everything together, and some people often get prescribed, I think, antidepressives, and I think actually there might be something else that they need. That was one, wasn't it? And that was number two. I think, and just to reflect what everyone else has said, there needs to be some kind of place, I don't know what that is, that has access to peer support, some kind of therapeutic support, you know, access to psychologists, a kind of a combination, you know, psychologists, psychiatrists, therapists, peer support, people in the community, where you can go and get advice or just meet people. Because a lot of the time, I think you do need holding. And I went to A&E twice because I was in a panic. And I actually think at that point, I just needed holding emotionally to say, keep the faith, you know, it's going to pass. And that wasn't the right place to go. But you do need some kind of system. And I don't think there's anything that, when I was looking, the first time I got the major depressive disorder, I just didn't think there was anywhere to go. Anywhere. And I rang on Mindstor in Brixton, and nobody answered, and I just kind of went home, feeling lost. There are some places that the councils provide, but I think I went to one called the Sanctuary in Brixton. I went there, no one else was there, and I just felt I didn't fit in. I was a bit odd. Didn't feel held, you know. Didn't feel like, if I'd met either of you two there, I think that would have been really nice. And we might have had a chat.
Yeah, just a bit of time. Not enough time is spent nurturing, really. That's what we need. We need nurturing. Sometimes it's like, oh, so you've been prescribed a diagnosis. Now we need to prescribe the rest of your life too. But in actual fact, just spending some time with somebody can be like a way of showing understanding, especially when there's been a shift in one's way of focusing outward and internally through that prescription. So I think, yeah, I really echo that. Some time spent would be, you know, a great asset for staff as well. I think that then it makes the journey more mutual, which I think is really important because, you know, doctors are trained in mental health. I mean, it's sometimes optional units, and they therefore might not attend. They might get away with it. But even for those who have, you know, an unusual interest in mental health, to get true mastery, it comes down not so much to what they have memorized, but to how much they've listened to people.
Thanks. Chris, did you want to add anything else, or is that good?
Just to echo that, it's about attunement, isn't it? And empathy, meeting people where they are, not looking down. You're right down there.
Yeah.
As a doctor, you get sympathy, you don't get empathy. It's not a good gateway.
You mentioned something about the Sanctuary in Brixton. I think you said it was not being the right fit, but also is this the concern that has been raised before about the 9-to-5 kind of structure of mental health services, when obviously mental health issues don't occur on a 9-to-5 schedule? Is that Ian?
Yeah, I mean, it brings to mind something that happened to me, which I've mentioned before, that I got to a stage one particular day where my mother, who's not very attuned to me and my difficulties, she said, "You're not very well, you really got to go and see somebody," and it was a Saturday afternoon. So the difficulty of getting anywhere on a Saturday afternoon where you can park in an A&E is probably well known to people in my borough, so I decided to go to the local walk-in. I got there and they said, "Well, we've got no appointments left. We'll let your doctor know you've had a crisis on Monday, but this is Saturday afternoon." And turning me away when I probably wasn't even fit to drive wasn't perhaps the cleverest way of dealing with my problem. And I know from what these gentlemen have said that I think everyone who's had difficulties of a similar nature have experienced similar things, that they're basically, you get asked, gentlemen, don't you, are you likely to harm yourself? And if the answer is no, and of course it might be no at that point, but 5 hours down the line on a Saturday night it might be yes, but the immediate reaction is, oh, well, go home then and we'll get the doctor to see you hopefully on Monday. Well, you know, that's not why I went in the first place. And just the general lack of understanding of if it's got to that sort of crisis point, you're presenting in a crisis, and being told to go home again really doesn't help anybody. I don't know if anyone wants to add to that at all.
I mentioned the sanctuary. That is after out. That is open. That's at night. And I'm trying to think, like, why didn't I didn't get access to go until I'd been ill for quite a while, and I think I'd gone further down. I wondered if I had that at the beginning, it might have been useful. There wasn't anybody there, and I didn't see a mirror. I didn't know, there was no one there, and then said, you know, and they just said, have a look round, and I sat down and chatted to someone for 10 minutes. I don't know, maybe that was my own shame. I didn't feel like it was a place for me, maybe because there was nobody there, I don't know. So it is difficult. Even when you have a place, you have to get it right, don't you?
And my experience is that, I don't believe that there's going to be like a huge upsurge in people seeking help if, you know, a 7 days a week system were to be introduced, because people often only seek help when it's truly necessary. So, you know, we might be looking at more flexible working instead of people who are suited to working weekends. Really, what I think is, from my own experience of being in a position where I had some floating support available to me at one point, is that I didn't tap into it even once. And I thoroughly believe that just its existence kept me well, just knowing that it was there, that I could. You know, that alongside having a space which is safe of my own. But yeah, once you've got that sorted, your own safe space, then what others can offer is, you know, a chance to talk about what's going on for you. So how are you doing in that space of yours that you call home?
Thanks. You said floating support. Does that just mean support that's there all the time, whenever you...
Yeah, so there's different names for it, like supported living, or like...
Right.
Yeah.
Okay, thank you. And just, I'm going to open this up in a sec, but one final question for me was, you've all talked about your experience with GPs and the GP as a gateway. How hard is it, or how easy, but I doubt that's the answer, but how hard is it to get a diagnosis and get the right diagnosis, and actually how important is that part, or is that part not important? Ian, yeah?
I mean, I don't think, apart from an early diagnosis of acute anxiety and depression, even when I was hospitalised, you know, I'm not really clear that the diagnosis ever changed. I think it's almost like a blanket coverall reaction. There's no drilling down into what that actually means. I mean, it was never really made clear to me, apart from that very loose diagnosis, what I was actually suffering from. Like I say, I mean, I entered the health service with mental health issues so long ago now. It was a case of, certainly when I was growing up, my earliest memory at school, secondary school, is being given Valium. Nothing that would actually be recognisable today as a treatment, just to quieten me down. And I had various psychosomatic issues too. But in those days, I don't think the actual ability to diagnose was particularly good or was actually there. You had doctors who had been trained after the Second World War dealing with you, and, you know, they didn't recognise PTSD, which we all recognise now. I'm dyspraxic, they didn't recognise dyspraxia. So things have changed, but in many ways, I think the doctor as a gateway is still exactly the same. You know, it is potluck, and there's a certain sort of resigned feeling from me that, does it matter what you call it? All I'm interested in is someone trying to help me. And there's still that feeling of lack of empathy or lack of understanding, or on the other hand, you get someone who's too empathetic, and that can be no help either. Often talking to peers is much easier and much more useful because of their experiences and their empathy, which comes naturally.
I think diagnosis is a tricky area. Why? Because in one way it's pathologizing and labeling, but in another way it does give you some information about what's happening to you, I suppose. Everybody wants to be in a group. I think diagnosis is all over the place. The GP will give you a general, diagnosis. If you see a psychiatrist, they're all licensed to give you a. So the doctor said I had depression, anxiety. The psychiatrist said I had a major depressive disorder. When I mentioned neurodiversity to him, he said, "Oh, I wouldn't worry about that." But I think, for myself, that the underlying trigger for all of it was autism and ADHD. Again, they're a bit of labels, because I think those things are full of constellations. But in my case, I go down wormholes. So I'm very sensitive to rejection, and then I'll drop into a wormhole and I'll get stuck in it. And I kind of, when I'm normal, I can jump in and out, or I go from one realm to another, but I got stuck in it. And now I know some of those things about myself. I can have strategies and understand and be aware, and that's the real help that I'm kind of getting from therapy and understanding. But that's because I work in the therapeutic community, so I have access to that. But I think a lot of people don't have access to that, and I think people need much more awareness about their triggers and what works for them, and how they can help every day to regulate themselves and not fall into the traps. And for someone else, it maybe can be different. Like Stephen said last week, his was something about low testosterone. Like, someone else might be something else, might have nothing to do with what mine was. But I think there are underlying causes. But the trouble with all of it is it takes a lot of time. And there isn't time because there isn't the money, is there? But so the putting peer support together might be the way.
Thanks. Chris, did you have anything?
Yeah, I think that it's a confusing situation to be in, to be struggling mentally. It's almost beyond belief that there could be something wrong with the mind when we spend all day working on it. Mental health professionals are really good at making decisions for people who can't make decisions themselves. But, I think the way we've got there is because we haven't been informed. I say that feeling that it took a trial by experience for me to see the positives in people, and also the huge depravity in which people take advantage of the power structures. But, I still think that there's stigma, and then there's a solution to somebody who is opening up, and that opening up can be seen as something which is the diagnosis, as opposed to their personal identity. And, I really do think that it should be mutual. So when I see somebody who is speaking to me in a way which doesn't sit well with me, then is to react to my gut and to say, well, how are you doing? But that isn't my role. And that's a very strange position to be in. It's even debilitating. And so I also think there's an element where that diagnosis becomes the norm. It's a self-fulfilling prophecy.
Thanks, Sean. So, Andrew?
These sessions work well when the answers are informed and the questions are rather stupid. So I'm probably going to ask a stupid question. What advice would you give to your younger self at the point where you felt that you were in some kind of crisis or on some kind of challenge? Where would you advise that younger person to go to seek help? Bearing in mind all your experiences with GPs, and I don't want to put any words in your mouth.
I mean, I can go first because basically 50 years ago there was nowhere. It's as simple as that. So at least working from that basis, we're significantly better off than we were. But
Sorry, forgive me. I was being too literal. Let's say a younger version of you now.
Oh, okay.
Younger version of you now.
Well, I would basically be there saying, reach out and seek help.
Yeah, but
Where? I mean, I would. I mean, you've got the way things are loaded. If you don't go through your doctor, you're not going to get access to a lot of things. So you've got to, whether it's sensible or good, as we've been discussing it, or not, you've got to go through the doctor to get access to social prescribing, which I would say certainly reach out for. Now I found that Mind and the services it offers are appropriate for me because I've been aware of the organisation for ages, and maybe this again is the male stigma thing. I didn't feel until very recently that it would be advantageous for me to reach out, but I got so fed up with talking therapies and things, and I just remember what it was like being in a hospital where there were people who were like me who I could talk to. I mean, like these guys I only met last week, and they're friends already because we've got that shared journey. We've done the legwork already, so we haven't got any difficulty conversing or relating because we understand each other immediately. And it's so to answer the question, you're still stuck with the GP unless someone can come up with some sort of brilliant new concept. But I would certainly say to my younger self, Mind is for you. Don't be put off by the fact that the people that I see on a Monday at the drop-in sessions are all of a certain age. I don't see any young people. In West London, I don't see any ethnic diversity. Well, actually, that's not fair. I do see some ethnic diversity, but make use of find out what's available and make use of it. Don't think that you have to deal with it on your own. But that's almost how it's only when it becomes a crisis that you reach out. And that's the point to get over. And when it becomes a crisis, to use the fire analogy, all the GP can do is put that fire out. It's not holistic and it's not preventative of regression. It's just dealing with the fire at that particular point. So I hope that's an answer, Andrew. I don't know whether that's... But you're still stuck with the same primary... There isn't an alternative that I can see.
Are they always the gatekeepers, the GPs?
Well, apart from going through directly to Mind, in which case I suspect they'd refer me to the GP anyway. Can you think of any ways around it? I mean, I throw it to the guys, I don't know.
No, it's always the GP.
Yeah.
Even if you get secondary advice, so you go and see a psychiatrist, the psychiatrist writes to the GP, but the GP just does what the psychiatrist says in a hierarchical structure.
What about any... because when somebody's I'm assuming, and please tell me if I'm wrong, when you're on the start of that journey, you don't necessarily know that you need the intervention of the health service, but you might need some other intervention. What would...
I mean,
What would that look
I
like?
can certainly answer it and say, you know, when I pop in a crisis, as I do every couple of years, because it's part of who I am now, and I accept that. I make the same mistakes again and again and again. I just don't, you know. Hopefully, if I can stay with mind and have regular sessions, that's great, because as soon as you get on a course with a psychotherapist or whatever, you're there for a fixed term if you do it on the NHS, and they have to get rid of you to make room for new people coming up. So again, it's a case of, at the end of your 6 weeks or whatever it'll be, in sort of parentheses, we know we'll see you again at some point in the future, but at the moment we've got to get rid of you to make room for more people coming through. So again, it's that lack of holistic care, that lack of future-proofing. You know, rather than saying, right, you're well enough now, we know you're going to regress, but we need to just push you to one side for the moment. You know, that if you, crazy analogy, but you wouldn't do that to someone who had cancer. It's an ongoing treatment. But with mental health, it's like, oh yeah, well, if you're not going to self-harm or kill yourself, and you've had a course of psychotherapy, and as far as we're concerned, you're much better now, it's like, cheerio, see you later, and in brackets, we'll see you again soon, which is not much,
So
you know.
they're not waiting around for stage 4, you know.
And you know, I mean, like I say, I continually make the same mistake. It's too late. I need somebody to tell me that I need to see somebody, because it's like, oh, I'll deal with it in my own way as usual. So I'm still making the same mistakes.
And can I, with the three of you there, I mean, you've all had different GPs, different experiences. In your view, you know, some GPs are trained, as you've said, Chris, and clearly some aren't. Do you think it's a minority that are trained adequately, or is it a majority, and you've been unfortunate enough to meet people who weren't trained? Or
No, I think most of them don't.
Okay.
I think, the mental health training is completely inadequate. They shouldn't be the gate. Your GP should not be the first gateway. There should be some. Well, they should have a training. There should be some. There should be. You shouldn't just be able to go and see a GP with a mental health issue.
Yeah.
That's not right.
Yes,
That really needs moving on. You might be, you know, better to see a psychiatric nurse or something. I don't know. But and what I would say to my younger self, I would say, you know, look after your mental health and love yourself. And like, you know, actually, often depression is when you go into your younger self, because you feel, and you've gone into that, and it's about self-love inside that's important. But it sounds corny, but that is really true. Because that is the thing. But it's finding places and people that you feel understand and listen to you, and they're empathetic with you, rather than telling you what to do. That's where you need to go. And I don't know, for some people that might be the family, for some people that might be the worst place to go. My family will all do this, do that, do that. You don't want anyone to tell you what to freaking do. Sorry. You want someone to get down and see where you are, you know? Sit in the pain with you. Hold it.
When I was at school, so my younger self, I would have loved to have somebody else from the school in an older year provide some support for me. But I did benefit. Later on, when I was in my final year, I became a peer support worker for younger years. And that was in a setting which wasn't unfamiliar. So my experience of a GP is that it's a short assessment, and it's a very strange thing to go through because it's completely outside of what we normally experience. So I would like to plug the mental health first aid training, which is something which is a 2-day course, and it can mean that just regular people like my younger self, helping that younger person in school, can have some training that enables them to hold a mental health crisis, to acknowledge one, and to help people through it, to signpost as well, yes. But it's the first point of contact, and it is, you know, for many people, it's an eye-opener to think about giving their time. And for some people, it will be that they've come from a point that they first received somebody else's gift of support. But it doesn't really matter where people come from, whether they start off by giving or start off by receiving. Just to normalise that mental health through something like mental health first aid.
And are there other people in the health service, apart from GPs, who can give support, do you think? I know we heard in previous testimony, which is quite confidential, so I'm going to try. We did hear that going to a pharmacist was actually a sort of a door opener to wider services. I don't know if that's an experience, Thiemann.
I mean, with the best will in the world, most pharmacists, whilst you feel that it's okay to consult them on minor things, I mean, bearing in mind our experience and, you know, of doctors, what chance is there a pharmacist knows even as much as a doctor? And I'm not being rude. It might be that my understanding of what a pharmacist can provide is totally wrong. But I can't quite see a pharmacist being trained on mental health issues and actually doing their job, because, again, unless I'm completely naive and wrong, in which case I need to be educated.
But I think it's about this general thing about if more people in the health service receive such first aid, mental health first aid training, it might make it a little easier to access those services.
Oh, I mean, if it was done, but I have to say, I'm well aware of the position pharmacists find themselves in at the moment, where they feel they're being overburdened.
Sure.
And I think something like a mental health emergency in a pharmacy, I can't quite imagine any version of me going into a pharmacy as a point of contact, because I would be presumably exhibiting signs of extreme distress, and I don't think a pharmacy is an environment where I would be happy doing that. I think it would just make me feel worse. So, and they can't prescribe anything over the counter that's going to help me anyway, so I can't quite see how that would help. I mean, again, I'm willing to be educated, but I just don't see how relevant that would be for me. That's just my honest opinion.
We talked earlier about normalising. Sean, you talked about normalising. Do you think there's enough promotion that takes place of normalising those with mental health stress issues? Sean.
Thank you, Andrew. I thought you were going to ask that, so I was ready with my answer.
Very good.
Because
I'm nothing if not predictable.
Because, you know, this might be like a reform session, but very often what comes out of reform is a disguise for cuts in some places. And one very cheap way of improving mental health is a public health campaign like Time to Talk, which, you know, is worth it in my opinion, and it encourages people to seek out help, which isn't statutory, or sometimes it's third sector, but quite often it's independent private sector, and they pay for it themselves. But it does acknowledge and normalise mental health. So, yeah, I mean, like, the more people who are receiving some sort of support for their mental health, the better.
And perhaps, is there signposting that could take place that currently isn't taking place towards mental health issues?
I mean, at the moment, I would say most young people get all their mental health tips and advice from TikTok and Instagram. And and YouTube. And you know, some of it's all right, but some of it isn't. So that's the problem. It's the filter, isn't it? I mean, there's some really good content if you know where you're looking. But so signposting the decent content would be useful.
Is that promotion from established agencies there to care for people with mental health?
Yeah, I mean, maybe there needs to be some kind of... It's so... The whole industry is so... I mean, you get clinical psychologists and they're kind of chartered, and then you get psychiatrists, and then therapists. There's all sorts of training, level 5 to level 7, and it's not clear. And I think there needs to be some kind of ratification so that people giving advice have got some, you know, level of clearance, something. You know, I don't know. It's difficult, isn't it? But... And sometimes, but is that, I mean, as I'm saying it, I disagree, because sometimes you just see some normal people talking and they really get it right. You know what I mean? They really understand the empathy and stuff. So I don't know how that process, I don't know how you signpost the decent stuff. I mean, in the old days, you had, you know, the BBC would get some decent stuff, but now that's gone, hasn't it? So how do you signpost in a world that is done by algorithms? The algorithms need some signposting information in them, and that's above my pay grade.
Thanks. Assembly Member Wilson.
Quite a lot of what I was going to ask has already been covered by Andrew, which is fine, because you did it in a much more thoughtful and eloquent way than I think I would have done. But just sort of picking up on the question of GPs as being the kind of gatekeeper, which you've all mentioned and all highlighted problems with why it's far from being a perfect system going through that route, but also the fact that there isn't a kind of clear alternative. What could be done to make GPs better at that sort of gatekeeper role? Is it just a question of better training and you know, wider training, or is there something else that could really help with that?
I mean, the fact is that they are general practitioners, and I don't see how, unless there's some radical reappraisal of mental health in general, how that's going to change anytime soon, because, you know, it's a very strange situation where you've got someone who might have a pulled muscle who's going through cancer treatment. You know, what other profession has to deal with such diversity? So are we just asking too much of doctors as primary caregivers? I mean, there was a point I wanted to make back to Andrew about sort of, which may be irrelevant to put in, you know, the doctor themselves can have difficulties. I mean, I raised last week a situation where a doctor said to me, I'm putting you on Prozac because it worked for me. Now, what sort of practitioner is saying that when everyone knows there are a wide range of drugs, especially when I said Prozac makes me ill, and she said, no, it worked for me, so I'm going to put you on it. Now, surely that tells you something about the level of empathy of that general practitioner. And it's the whole term, general practitioner. It sums it up. You're good at some things, you're a specialist in some things, but you're an expert. Beware of experts, I always say. You're an expert in what? So I think that answers the question from me, unless there's a radical rethink. And as I say, it's above all of our pay grades probably, but I think everything that I've heard from my friends here, it just highlights the fact that it's just not working at the moment, and that's all I can say.
I don't know how you do it. Is there, you know, is there something between a doctor and a psychiatrist? Is there a level? Can can GPs have an extra year of mental health training? I don't know. I don't know how the training works. I think go from doctor to psychiatrist is quite a big jump. Is there a middle bit? I don't know. That would help. Huh?
I think it's 2 years.
Yes, 2. Okay. I don't know. So But that, again, you know, I hesitate, because what do they know? I mean, to train as a psychotherapist takes 5 years. You know, and you almost want a psychiatrist that's done psychotherapy, and you got someone who really knows what they're talking about. You kind of need a bit of everything. So that's hard, isn't it? Because we're in a kind of science-based. I don't know what you would do, or at least I would say that not. If you've got a mental health issue, you shouldn't just go to a standard GP. There needs to be some, especially somewhere like London. I'm sure you can arrange it. It's big enough that you can flow, you know. Mental health, it must be possible.
Perhaps the biggest improvement would be just the speed at which you can be referred to a different, more appropriate service then, rather than being stuck with the GP.
I think speed's a big thing, and especially with medication, because there's a thing, take your medication, wait forever. Then, actually, when I'm seeing psychiatrist, he said, oh no, sod that. If it doesn't work in 4 weeks, change. Doesn't work in 4 weeks, change. Doesn't work in 4 weeks. That to me makes sense. If you're not seeing any improvement at all, move. But that's going down a medical route only, isn't it? It might actually be that is not what it is. It's kind of by chance almost, isn't it? You're just plucking at straws, which is a bit scary, but it seems to be that's how it works. No one seems to know why things work. You know, that's kind of, you're going through a pill lottery, aren't you? But if you feel so desperate, you kind of do it. I did, and I went from 1 to 2 to 3, you know, but I didn't. He sped up the process. He said, doesn't work, move. He said, don't wait 3 months out of your life, you know.
Yeah, I'd just like to say that I think a lot of people struggle to take their medication, and I think that for one thing, it's the side effects. Like, all psychiatric medications have side effects. I want to be real about that. It's not 1 in 10 or 1 in 100. Everyone can feel it on them. Maybe if on a very, very low dose, then that's better. So get people onto the low dose. But it's, again, stigmatizing to take medications. So, yeah, that's the first thing, you know, that it's good if somebody who is experiencing a mental health crisis has gone to their GP and has a few questions for the GP themselves. But I don't think everyone has questions to ask the GP. You know, I know that I like to write down what it is that I'm going to say to the GP and then bring it with me. You know, it's much easier now over the phone because I don't have to bring it physically with me. But and so, yeah, one way it could be better is like, I guess, a preparation meeting with somebody for that GP appointment.
Member Harani.
Thank you, Chair. Chris, I was quite interested to take up just ask further about the point about social media and how people are accessing or using TikTok and other social media channels to kind of look at advice. But also on the flip side, there's also lots of concerns about what's on social media and the kind of advice that's out there. Are you kind of aware of maybe the flip side and how that could be perceived negatively by some people as well?
Well, yeah, of course. It's, you know, there's lots of stuff, isn't there, on social media about men stuff and the toxic masculinity and Andrew Tate and all that. I mean, I think from what I know, the research shows it's not quite as bad as it might be. But I think the only thing you can do with that, isn't it? It's education. It's really important to teach kids and young people to be able to to have their antennae, to know what is good and not, because you used to have trusted brands, didn't you? Used to have trusted, you know, the BBC or the whatever, I don't know, the Times or whatever. But now you don't know what is, there's no trust. So there's no trust in anything, but I mean, you know, I'm a therapist now, and people come in, especially the women, and they always say, "Oh, I saw this on TikTok." And I think actually, if they're in therapy, it's okay because you can talk about what does that mean for you, and you can navigate that piece of advice. But I don't know when I navigate the content to look at it myself, I see quite a lot of stuff that's okay, to be honest. I don't think it's all that bad.
Yeah. No, sure, so that's
I think there's a lot of good stuff, but it's what you do with the information. Because then people get awareness and they might label themselves, but then what do you do with that? I might be ADHD. Okay, but what does that actually mean? How does that navigate your life? What do you do with impulsiveness? What do you do that you've got multiple attention on different spots? How's that working for you? And that's the thing that the social media doesn't do. It doesn't tell you how to apply it. People just, it's like a buzzword in the pub, isn't it? And that's the bit that's missing, I guess.
Sure, that's fair. And also just thinking about, I think you've all spoken about kind of what works for you and what has worked for you. And from what I'm hearing, peer support has come out quite strongly. And also we've spoken a lot about GP services. Is there, does anyone have anything more to add in terms of what services maybe didn't work for them personally, and maybe shed a bit of light on any reasons why, apart from the ones that we've discussed? Ian?
I mean, when I had my last period of illness, and ironically that was because I had to change my medication because of side effects. I had 6 months of purgatory because the medicine wasn't working, but I couldn't contact the doctor. And I was told off for not trying, and I said, I couldn't get past your receptionist. She said, didn't you say it was an emergency? I said, yeah, but you're working a rule at the moment, apparently, and they wouldn't pass it on. So, you know, I wasn't best pleased, but anyway, that's a total aside. I mean, I don't really know what to say in.
Welfare and housing.
Thank you. Assembly Member Ahmed.
Thank you, Chair. Good afternoon, Ian, Sean and Chris, and thank you for being so honest with what the information that you've given us. Ian, I want to backtrack on something that you said earlier, and I actually found it very moving that you went to the hospital. I think for me it would be a very brave decision to go to the hospital, to acknowledge that there is an issue that I need help with. I think it takes a lot, particularly when you're not in the best place to do that, but your mum told you to. And I found it really difficult when you said that they said, yes, you are in a crisis, but we're going to contact and we're going to let your GP know on Monday morning. Well, if anyone knows anything about GP practices, Monday morning is the worst possible time for anything. You know, the last time I rang on Monday morning, there were 30 people ahead of me in the queue. So just what do you do with that? And what needs to happen, in your opinion, to change that you're not told that, you know, you're not going to have a response. It's something's going to happen in 36 hours' time, despite the fact that you are here in front of us in this situation. And then goodness knows when the GP will get back to you that day, if you're lucky.
Well, I know from what I've heard from the gentleman here with me that we've all had similar experiences. I understand, to clarify things, that there is a standard that A&E is supposed to have, but there's no point in having a standard if it's not even a realistic standard. I don't think any of our experiences have measured up to any sort of standard at all. And I mean, when I was rationally thinking about it, as I think I said, I wasn't fit to drive. Surely there was some duty of care that told them that I shouldn't be, you know, I was potentially a menace. I'm not incriminating myself by saying that, but the only way I could seemingly get there safely was to drive. And then to be told, well, we're back to that 9 to 5 thing again, aren't we? If it doesn't conform to the availability of services, then if you're that wonderful question again, are you contemplating suicide or are you going to self-harm? If the answer to those is no, then we can let it go. We'll see you on Monday. And I think I was seen on Monday because, you know, I mean, I have got a history, so that's fair. But again, you're quite right. If you've got a surgery where, I mean, and by Monday I was feeling better anyway. But it doesn't follow that I would have felt better that evening. I mean, you know, if I'd had anything, any sort of sedatives or something, I would have taken, you know, I would have self-medicated and sedated myself because that would have helped. So again, the basic common sense that we've all got, you know, we sometimes it is a case that we know best and we know how to treat ourselves, but, you know, as I say, I'm knocking on towards 65 now. So again, I'm looking back and sedation was the way that I was dealt with when I was a teenager. That was how the doctors prescribed. I just want to say something about the, you know, the lottery of medication, which I hadn't picked up on before. You know, like the doctor who said Prozac works for me, anyone who knows anything about medication knows that's the most ridiculous statement to make. It's patronising, it's ridiculous in the extreme, because the sertraline which I was put on made me ill for 6 months. But I couldn't do anything about changing that medication because I couldn't communicate with the GP. So getting back to a point which I think has been well made elsewhere, you know, that gives you some idea of the situation where it's, oh, well, this one doesn't work, well, we'll try this one next. And the fact that I was very happily on a medication, told to change because I was getting migraines. Can you imagine a couple of weeks ago I had another severe migraine and I thought I've changed my medication for no reason and been through 6 months of hell as a result of that. That may give you a better overview of this sort of lottery because the medication that we're taking doesn't necessarily work. We might be on 3 individual things. But, you know, to address the point, I mean, you know, this seems to be a standard hospital response if you go to A&E. And how does that help anybody? I really, you know, you've said it yourself. How can it help anybody? I don't know. I wonder how many of the people who aren't seen go and do something silly.
What would you like to see? How would you have liked to have been treated at that point rather than being sent home?
Well, I wouldn't have liked to have been sent home, even if I was just there for observation. But I don't think there was anyone qualified to make that decision. And if there's no one there qualified to make, and we're back to again, even if you're in A&E, you're not a mental health specialist, are you? Not necessarily. There probably isn't one on site. So I can say with the best will in the world, could they have done any better? Yes, they shouldn't have let me go because I possibly was a menace. If I'd have gone into the back of another car or run someone over because I wasn't thinking straight, then that's on them. But I just don't know. Again, you have to forgive us, but there is no, it's difficult for you, I appreciate. There is no magic answer. All I know is that it's not right. It's clearly not right. I mean, if someone was unable to see, would you let them drive? That's something you can say, that person can't see. That person is too mentally unbalanced to drive. If there's no one qualified to make that decision, as there clearly wasn't in my case, well, go home again. That just shows you how little expertise. I mean, I don't want that to sound bad, but how do we address that? I don't know. It's a rhetorical. I'm just bouncing it back on you guys because you've probably got greater experience than me in this, but I know it's unsatisfactory.
Can I ask, and thank you, Ian, but Sean and Chris, do you want to add anything to that from your own experiences, perhaps, or from experience that you're aware of?
I think what I would have wanted was some kind of acknowledgement that things were really bad for me and that somebody with some psychiatric know-how or some know-how of medications was gonna like know what's going on for me. I got that in the end because I paid for it. So it's obviously there, but I had to pay. You know, and so it's like I would override the information of the doctor every time. I couldn't sleep. He said, you can't have sleeping pills for more than a month. And the psychiatrist said, rubbish. Of course you can. And he said, as soon as your depression lifts, you'll go off them. True, depression lifted, went off them. I wasn't addicted. And he gave me hope. He spoke with some authority, but maybe that isn't, maybe someone else can speak with authority. It isn't I don't know, it could be somebody, I'm not saying that is the answer. But I felt that he knew what he was talking about and he'd been in different, but maybe that could have been from a peer group person. You could have said, oh, Chris, in 6 months, you come out of it, mate. I just didn't feel, the doctor, I just felt like I'd come out of university and didn't know. And my family just thought I'd gone mad. You know, and your friends just kind of, they're just your friends, aren't they? So they can't really do much.
Thank you. Sean, did you want to add anything?
This seems like a case of, Ian, that you didn't know that that's what they were going to say and that the only place for you to present really was the A&E, but you didn't go there. So I think a lot of people in that position, they think, oh, well, I'm not a crisis, but I could get there. So then if they know that they're leading up to one, then it just seems that, okay, park your car here and we'll get an ambulance, we'll get you a taxi to A&E, if that's where you need to present to. If you're saying to me, oh, you can go and present there, it's a gamble, isn't it? I mean, it's not a laughing matter to give somebody that challenge to get there, knowing that they might fully well leave thinking, I'm not going to go, and then...
I think the hospital, I think it's because it's tangible in your head and you're having a crisis. It's the hospital, that's where people go to get help. There's doctors, there's people around. I'm here. I'm somewhere. I'm not at home. I think that's why I went twice. It's just, it's a cry for help. And that's the only place, surely there must be somewhere else more practical that I can do that. Or could have done that. It's a tangibility, I think.
Thank you.
Just something to add. I mean, when we had our discussion last week, I mean, I heard a lot about the sort of drop-ins and things, but again, Richmond is well funded, but I don't know. I mean, there's a drop-in available in Kingston, but the next borough to me, but it's not available in Richmond. And Richmond, we haven't even got a men's group with Mind. We're working on having one, but there's just no, whether it's funding streams or individual, parts of the organisation, but there's no consistency at all between boroughs, irrespective of health service areas. There's just, I mean, how can you promote something when there's actually no consistency in what you can expect? That is a rhetorical thing to think about. Across London there is no consistency at all in what is available. That's where maybe your advice may well have value.
Thank you. Thank you, Chair.
Thank you. Andrew?
Yes, and the Greater London Authority, or the Mayor, has no remit over health service, but we do have a remit over health inequalities. And the Mayor has a lot of tools that is in his control. What do you think the Mayor could do to raise awareness about mental health issues for men?
I mean, just putting it in the public domain and trying to get over the fact that there should be no stigma attached to it. So I have a very personal worry that and again, something I stated before, that I think the statistics show that people of Afro-Caribbean background are much more likely to have mental health issues, whether that's, cultural or whatever. But I don't see much diversity here talking to you, and that might be just because they're just not able to communicate that, or they don't want to communicate that, or whatever. So trying to make out if there is any issue why certain people from certain backgrounds won't engage. That's something I think the Mayor has been exceedingly good at, getting to all communities, Muslim, Afro-Caribbean, whatever. I think the Mayor is a paragon of virtue in that, making people in London feel included. And I mean, the current blood plasma campaign that's on the radio, I don't know whether that's come from the Mayor's office at all, but, on local radio, it's reaching out to Afro-Caribbean people saying, we need your plasma. So this is the sort of thing that the Mayor of London can do and can target audiences in a way that, for whatever reason, I don't think other politicians seem to be able to do. But I'd just like to see a London-wide approach. I mean, if you can make strong advisory comments without having any influence, you can make, or the Mayor can make a strong advisory comment that there's some degree of continuity across London. Because, as I say, how can you promote men's mental health if it's a lottery, dependent on which borough you're in, what sort of services are available? I mean, surely that's a pan-London issue, which is exactly what the London Assembly should have some say in. I mean, if it can deal with public transport across London, one could argue that mental health is something that should be dealt with on that same sort of scale, not in terms of funding, but in terms of promotion and in terms of trying to get some sort of cohesion across the boroughs.
Is there anything the Mayor could do with regards to the public perception of men's mental health?
Well, just keep making on the point that it's he's good with diversity. Just to say, we are a diverse community, and the mental health community, is a community, and it's not something to be stigmatised. It's something to be. Help me, someone. I can't. It's perfectly normal to feel like we do, and it's part and parcel of life. But somehow we're not empowering individuals to take that on board. I don't know. I mean, if the Mayor was here today, I would say to him, "You're a reasonable chap. What could you do?" And I might have a conversation with him about that, because he might suggest something wonderful that I haven't thought of.
I think this is great being consulted upon. It's one of the stages up the rung towards co-production, and that's been around since 1969 with Sherry Aston, by the way. What you talk about there, Ian, is I resonate with. I would like to say that it's not just the public's perception of mental health. I don't know how anyone viewing this will have interpreted Ian's comments about there not being a representation of visibly diverse ethnic groups here. So yes, listen to the third sector in each area to represent things with both a local and a London-wide perspective. And if you're not already aware, there's huge inequality in the perceptions of psychiatry, in that black men are 10 times more likely to be sectioned than white counterparts. So, you know, I would happily yield lots of my interruptions today to anyone else who had a more grounded perspective on the matter. But, you know, I certainly feel that I've experienced better mental health treatment due to the way I've been perceived. So, I mean, hopefully you listen to everything I say and implement them.
So I guess what we were talking about there is systemic oppression, isn't it? So, but we're in the system here, in this system. In a white, mostly male. But, so, I'm not sure that he's going to do that and talk about that. But I guess at least there could be some kind of promoting some kind of role models or people to come out. Can we get some famous Londoners to come out of their mental health? You know, can there be some kind of talk about that? And also some kind of celebration of kind of, or just some kind of, you know,
I mean,
extreme neurodiverse pride, you know, it needs to celebrate difference. And that needs to come from mental health, not, it's done on all the sex and sexuality, it needs to come to health pretty fast and to neurology. That's what needs to happen.
I mean, if I could just add, I mean, I think, you know, it's clear that I like a lot of what Sir Sadiq does, but I mean, you know, why not have a mental health celebration day in Trafalgar Square or something? You know, I don't know. We get all sorts of diversities, and I applaud that. But hey, this is the diversity that almost everyone has had experience of. And maybe, just maybe, if we celebrated it rather than looked at it as something that, you know, there's that funny bloke who sits in the park, and don't go and talk to him when you're young because he's a little bit odd. Rather than looking at mental health in those terms, maybe we can think of positive role models and actually, like you say, I mean, we've got so many people who are expressing their difficulties with mental health, but we need representative Londoners to do that. I think that's a great, you know, I like that idea. I think that's really bang on. It's if you can see someone like you going through a problem, you're more likely to identify and do something about it.
Thank you. If I may, it sounds, Chris and Ian, like what you're talking about is some sort of campaign, and you probably won't know this, but it's a health committee tradition to talk about the TfL estate and the fact that Mayor has access to the TfL estate and to put advertisements up. So would some sort of TfL campaign where there were posters and signs on the underground celebrating men's mental health or talking about struggles and being representative, would that be something as part of that would work?
Look, it's better than not doing it, isn't it? But I'd say you would have to. You wanna consult with some, you know, with the creative part, because a lot of TfL creative's done in-house, and you can tell. Sorry. So can you get an agency to do a bit of pro bono work, and can you get someone like Mind in, and you know, then I think you might be cooking. But yes.
Yeah, in fact, to open that up, the question would not be, should Mind be given some free advertising space to run a campaign?
Yes. And, you know, with some, mine can go and get that help from the, the creative treat's really important, isn't it? So get the tone right.
Yeah, so I don't know, but I have never heard, if you see somebody who looks unusual, text or call, mind. I hear that about another service very regularly, but I don't hear that about Mind for mental health service. So if that could be plugged, that'd be fantastic, getting support to people. Seems kind of like outreach is what I'm saying, something rather than just something cheap and passive.
I mean, I remember when the Poems on the Tube started and things, and people do look, if you're commuting, you look at what's up there in the tube train. So I would certainly want someone like Mind involved in it. But again, we're back to the problem that if even Mind can't offer the same services in every borough because of funding issues, then it's not about the services they offer, it's about knowing who to contact in a crisis. And I mean, I can think of campaigns, public health campaigns that have gone completely wrong. I mean, I'm thinking about the AIDS campaign, which the government put out, which was just hideous, and it just made everyone in the gay community really scared. You've got to be so careful, so you've got to get people in. But getting creatives in is one thing. What about the mental health, the community doing something, encouraging people to perhaps put a little care, I mean, I just loved the fact when I met Sean and he just immediately said, because I described my 50-year journey, and I remember very much, he just said, thank you for sharing that. And that's so sincere coming from him. It might not be sincere coming from a doctor, because I've heard it all before. So, a little message from somebody, it might be a message from me saying, if you're reading this and you are in difficulty, don't make the mistake I made, give Mind a ring. Something along those lines, where it's clearly coming from a person who has had experience. Back to that sort of caring thing again.
I'm just thinking, could you, so put the two together, outreach, and use the TfL estate? So could you have, a team of outreach people going around, into different stations, visible, so it's all branded, gets the awareness. The outdoor doctor, whatever, the mobile doctor used to go around pubs and stuff. Can we do that? So I know, with a bunch of different people, it might not last forever, but it might get everybody, it's a good thing. It might start the conversation going.
I mean,
might get people on the way home, on the way might be a bit busy, but I don't know. Yeah.
In a world where so much is sound bites, I mean, I could quite clearly see that on the various TV channels. It's something that it would easily make the news locally. And again, anything that puts it out there in public domain, back to reputed sources again. If it appears on London News, on ITV or BBC, people are more likely to pay attention, or Channel 5, BBC Breakfast, any of those outlets who always seem to be looking for that sort of story. I can see that would be very good for the perception of London and its caringness, which I believe in. If something like that was done at Waterloo or Victoria or under the Major, and maybe rope some of us in just to say that this is authentic, this is not a publicity stunt, because people are always going to say, oh, well, that's that. But, if we were there and said, hey, let's help each other, let's do something, I think that's an admirable idea. I really do.
Yeah, thinking about the estates that are in London is councils have a lot of land, and land can be used to grow on, and I think the community should also be about exchanging resources, skills, or something like that. So for men, activities are particularly useful if we don't like talking about things person to person. Sometimes we can bond over an activity. I fail to see how TfL does that, I mean, lots of people who are in mental health crisis aren't going to be travelling on public transport, and if they are, then I think it could be made a lot more accommodating. So yeah, I do think, to answer your question in short, instead of giving a discursive, is that some publicity on the advertisement boards would be good.
Great, thanks. And I'm really sorry, Ian, but just because we've got a second panel, we are going to have to wrap up. But with the caveat of, a bit like I said last week, if you do want to give any further evidence, I think we were really getting into some nice solutions and things at the end there. If you do want to do that, please drop an email to Tim or Diane, the team, whoever you've got contact for, or Lucy's got contact for. We will definitely pick that up. So please let us know after this session, and we can still take that as evidence as part of this investigation. But with that, and with it in mind, Ian, what you just said, and I hope it comes across as sincere, because it is, thank you all so much for being here today and sharing. I think health, as well as family relationships and stuff, is probably the most personal stuff that you could share in a public forum. It's not easy, so I certainly am really thankful, and the fact that you do that means that we are able to have a more informed piece of evidence, which will hopefully help others have a better service than you've experienced. And so that really is all we can hope for, and your input into that has made it so much better. So with that, can I thank our guests for attending this first panel of our afternoon session, and we'll now take a break for 5 minutes, coming back here at 3:35 for our second panel. And I'm going to close the meeting there. Coffey OBE, Mayoral Health Advisor, Dan Barrett, Director of Thrive London and Good Thinking, and Good Thinking, Co-Director of PHI UK Mental Health Consortium, Karen Bonner, MBE, Regional Chief Nurse, NHS England, the London region, and Dr. Billy Boland, Regional Clinical Director for Mental Health, NHS England, the London region. Again, I hope that was all correct, and you are all correct and present, so thank you very much for joining us here this afternoon. With apologies to our other guests, before I ask the first question of this committee session, I wanted to address a question on committee business with you, Tom. The committee would like to express its disappointment and concern over the length of time it's taking for response from mayoral recommendations. Currently, we've got 5 overdue responses from the Mayor, including responses to our eating disorders in London and Healthy Living for All reports, which were published in February and March of 2024. The responses were due in May 2024. So could I ask you, with impetus, to please try and hurry those up, or perhaps provide a response on the wait?
Yeah, first of all, just to apologise for the delay. We do value the recommendations from your committees. I, in fact, was aware that this is an issue, and I've spoken to the team again, and they are trying to get as much detailed, responses to you. I'll go back to them afterwards and just say, a timely response is really important. Going for perfection often delays things to a way which, doesn't give you the response you need appropriately. So I'm sorry about that, and I will talk to the team afterwards. But thank you for raising it.
Thank you. And with that said, we'll move on to the session for men's mental health. And Tom, I will start with you as well, and just ask if you wanted to give an overview of the Mayor's current work on men's mental health and anything in this work that you wanted to highlight.
So first of all, thank you for inviting me. Now, I know this is a committee that meeting is looking at the evidence to try to find out, what do we need to do more in the area of men's mental health. I'm here, obviously as the Mayor's Health Advisor. I'm also here as a GP. And at a meeting like this, I'm quite keen to hear from yourselves, await your recommendations, hear from colleagues around the table to find out what is the best way forward. I'm very much aware that there is a government consultation on this field. I think it's consultation ending on the 17th of July. So I've spoken to the Mayor's office and colleagues to say we in fact will, because of this committee as it happens, we don't normally do responses to government consultations, but we actually will be doing a response to this consultation because of this committee. So, and this might be cheeky as me taking months to reply to you, but it'd be really, really good if the outputs, even the draft ones of this 2 series of meetings, is available before the 16th of July to allow me to use them to put in our GLA response to the government's men's health strategy consultation process. So that's what I'd like to say first of all. And so therefore I'm here to listen as much as to kind of pontificate. The Mayor's approach is always do things, spotlight, convene and advocate. And Sadiq for mental health, he has disclosed his own difficulties at times of mental health. Did an interview a few years ago in the GQ magazine where he talked about how difficult he found COVID and how he learnt how to, there's lots of things you can do, not only just to improve your physical health, but you can actually take active steps to improve your mental health. And that was something he has always advocated to colleagues. The suicide data that we've got, for people who are death by suicide, does show some significant issues for London. First of all, London's suicide rate has gone down from 10 to 7 the last kind of 15, 20 years, which is fantastic news for us, unlike England. But the proportion which are male and female is very much preponderance to male. And also it's a real geographical shift, whereby Hammersmith and Fulham have the highest levels in London, and Brent has the lowest. So, and that's literally double the rate. So there is quite big differences in London. The approach that I suppose that we take very much is when you look at the mental health issues for men particularly, and the deaths by suicide, a lot of it isn't due to necessarily established mental illness, it's due to life events and life difficulties, for suicide particularly. And therefore, can we address those things which produce those adverse lifetime events like poverty, rough sleeping, poor housing, unemployment. Therefore, you'll find in his health and all policies work, he's done lots of work in those fields. But also in the field of mental health specifically, one of his major areas of work is in Thrive, funding Thrive £4 million over the last year with a number of campaigns on zero suicide, mental health first aid, and I'm glad that Dan Barrett is here. Sadiq himself has done his own mental health first aid training, and he's persuaded his deputy mayor to do it with him. He's done his zero suicide training as well. And in fact, I think a quarter of all London councillors have now done mental health training. And he has tried to lead the way, lots of council leaders have also done, to say, you know, let's lead by example here and do our own training. We would also kind of look at the work we're doing going forward now in our HIS, where we've got an approach looking at mental health in schools, the whole school approach to mental health in schools. Secondly, looking at young people. Can we really deliver 250,000 opportunities to children and young people? A lot of them focus around their mental health. And then also looking at LARCH, which is the London kind of anti-racist collaborative for health, something which we're hosting and leading on, to work with our health colleagues like Karen and Billy to say, what can we do to make sure that health service, you know, responds in an appropriate way for the poor mental health of black people in London. One thing I have to say is Sadiq does not commission or run any NHS services in London. His job is to convene, to spotlight and to advocate, and also to do the things which address the determinants of poor mental health, and that's what he tries to do. Thank you.
Thanks, Tom. And yeah, on just to come back to the point around the 16th of July, I think Tim might have a heart attack if we produce our output before then. But I think certainly in the next week, perhaps myself and the Deputy Chair can get on a call and agree some basic thing to then send to other members. So hopefully I would love to have the opportunity to make sure that's in. Yeah, I'd love to meet that challenge and definitely get something to you by then. And just, you mentioned as well about Steve talking about his own challenges, which I don't know if you caught the tail end of the last panel, but that's what our lived experience users were talking about, is people of high profile talking out, and I think that was certainly helpful. I also saw there was some social media with the mayor on a construction site just either shortly before our first meeting of this session or shortly after, which I also wanted to take some credit for our spotlight shining, that he's doing that. I'm going to take the credit either way, but I certainly recognise that things are happening. But one of those things, obviously, through your work, Dan, at Thrive London, a question for you, I think, firstly, on what key initiatives do you think you've delivered that have related to men's mental health?
I'd say there's been several. I guess to just provide a bit of context, Thrive London is a partnership that's supported by the Mayor of London. Our funding comes from the GLA, it comes from NHS London, London ICBs and London Local Government, I guess, are our main sources of funding. And there's been a few key initiatives that we've done and that have seek to engage with and or support men. Obviously, Tom has kind of touched upon suicide prevention with the regional lead for suicide prevention on behalf of NHS London. We are a small part of suicide prevention activity in London. Many organisations, regional health agencies and beyond, ICBs, VCC organisations are all involved in that work. But what we're doing, I guess, are to us a few key critical pieces of work. We convene London's suicide prevention group with over 50 organisations and people with lived experience. A part of that group, we created and now maintain London's real-time surveillance systems for suspected suicide, attempted suicide and self-harm. And we deliver training and campaigns, I guess, the three main components of our suicide prevention programme. And the Zero Suicide London is probably our biggest campaign or training within our suicide prevention programme, which has seen more than 450,000 Londoners take free online suicide prevention and awareness training provided by Zero Suicide Alliance since that campaign was launched in 2019. We're very, I guess, mindful within our suicide prevention programme of the disproportionate risk to men. And yeah, I guess our programme understands the data, supports systems in London and organisations in London to deliver activities that seek to address that disproportionate risk in men. Another key area of activity for us is our Economic Wellbeing Forum, which, although it isn't, I guess, directly targeted at men, we acknowledge that financial difficulties, secure employment, these situations are important to everyone's mental health. There's evidence from the Adult Psychiatric Morbidity Survey that they disproportionately impact men, and employment status disproportionately impacts men's mental health. And so we have a long-standing programme of work that is looking at that relationship between financial adversity, employment and mental health. And it's the forum has around 30 members, largely VCC organisations, statutory organisations, and we co-develop activities with them. We recently launched, or recently started delivering 3 projects, one particularly looking at developing a mini-series focused on financial well-being advice. A second project is looking at tackling stigma associated with financial hardship and poverty, which is a key barrier to people accessing support. And the third project is a project will resolve poverty, where we're trialling, I guess, a tool to better integrate financial advice within health services and other kind of public settings like schools, etc. And the last one I'll mention is our Right to Thrive project. So this was an initiative we delivered between 2018 and 2024. It was broadly about understanding marginalised and racialised communities in London, the disproportionate risk to their mental health, and working with community groups to commission activity to work to deliver with and for their community. And a number of, although it had a kind of broader focus, and we funded lots of different activities, lots of different types of communities across London, we did fund some activity that particularly were for groups of men who are disproportionately at great risk of poor mental health. So, for example, we supported a community rugby club to deliver a project particularly for black men in West London. We funded Bangladeshi Mental Health Forum to deliver a project with men within that community. So yeah, there are several projects from that report, and I guess I should say the Right to Thrive initiative, in terms of the grant giving aspect of it, was funded by the Mayor of London as part of our grant agreement.
Thanks. So just following up on that, and we will get into Right to Thrive later, so I don't want to tread on too many toes, but just if we're talking about directly funded projects that focus on men, out of the work that Thrive London has done, it comes down to those 2 Right to Thrive projects that you mentioned at the end. The other work is the wider work that helps men, or have I misunderstood?
No, I'd say that's correct in terms of directly working with men. I'd say the other areas of activity I've highlighted are speaking to wider determinants or inequities that evidence suggests are more prevalent within men. Okay. So, yeah.
May I just say 2 things just about 2 particular groups. One is the rough sleepers. 85% of men are rough sleepers. And in the offender management programme, which we do by VRU, 95% of those are men and boys. And therefore, the work we've done then is very much tailored towards working with men. And both of those groups have a significant mental health contribution to the cause of those 2 issues, and also the input we give to those 2 issues. We have mental health support to rough sleepers, equally to the offender management programme. So they are 95 and 85% men. So I would argue that it's a predominantly male-focused piece of work for a mental health intervention, which all of us at the GLA support.
Are we clear about that? I suppose you're saying, it's something you take into account, or not you specifically, or when that work is perhaps commissioned. But is that something the GLA is clear about? Essentially, this is services catered for men.
It's services catered for a group with definite mental health support going to the vast majority of male clients. It isn't a service only for men. there are rough sleepers who are women, there are offender management program attendees who are women, but 95% and 85% of those two cohorts are men. So when we're talking about work focused on men, I would say that those are two cohorts which they are not just in the majority, the vast majority.
Okay. Assembly Member Harani.
Actually, that's quite a helpful theme for some of the questions that I was going to ask, because I was going to ask about firstly the Zero Suicide London campaign, but also Right to Thrive, and then the health inequality strategy. All have been mentioned in terms of what it's delivering, and also the impact and the numbers and the data that you've already presented in your opening remarks. But just on that, because it's just by virtue of looking at how all of these areas and the areas that disproportionately impact men, are services designed in that way, or is it just to meet and reflect that need, or is it something where you're looking at a topic or a subject area, and then the data comes in afterwards in terms of how to look at who is impacted and how you respond to those? Is there a thought process that goes on before that in how you're going to tackle these important issues? And I think let's take the example of Zero Suicide London, Dan, and how does what you deliver through there then make sure it's impacting on the groups where the data is suggesting you should be following?
I guess what I'd say is that everything Thrive London does is informed by the evidence base, firstly, in terms of the risk and protective factors for people's mental health. So there's an evidence base to support the activities that we're delivering. We also support, I guess, significant community involvement or co-development of our activities. So we particularly work with the groups that we're trying to reach through our activities to understand appeal, if it's going to meet kind of their needs and that type of stuff. And so I guess with the Zero Suicide London campaign, anybody can take that training, but we've done particular activity to engage with certain sectors and certain kind of groups, I guess, that we know are at greater risk of suicide and self-harm.
And Dr. Gough, you mentioned some of the data around London and the significant progress made on suicide, even if you compare with areas outside of London and other parts of the country. Do you have any insight as to why that might be, or any reasons why we've seen that sort of positive trend in London?
I can't prove cause and effect, to be honest, but I know that the Zero Suicide campaign, which has been led not just by Sadiq, but all people on this panel and the NHS and colleagues, its desired effect is to reduce the suicide in London. There's a campaign or a group called Papyrus, which again is a thing which the GLA does directly fund, trying to train people, educators in the schools and FE colleges to try to address suicide. The mental health first aid training, which we've done in schools over the last 7 or 8 years, 4,000 educators have been trained in that. And that again is focusing on children and young people. One thing I would comment though is that the age group, which is the largest age group that commits that takes death by suicide, is the 45 to 49-year-old males. So in fact, that is the middle-aged males. We've worked a lot with children and young people, and generically via the Zero Suicide. So it has been a really cross-agency approach, a really bipartisan, non-political approach. I've had great support from the Tory councillors, the Liberal Democrat councillors. It has been quite an impressive, pan-London campaign, and I would hope that has had an impact. But I know that compared to the rest of the country, ours has gone down significantly, and so I think that's credit to everybody here who's taken part in that work.
And Dan, Right to Thrive. So, do you have any data or insight on the impact of the projects that were commissioned and the impact of them?
Yes, not to hand, but we published an impact report of all activity that was funded, so I can share that with the panel.
Yeah, sure, I'm sure that will be helpful to have. And you mentioned it was a 2018 to 24. So what's happening now? Is that work being taken up elsewhere, or has other funding ensured some of those projects go forward?
I guess that scheme as a kind of initiative, as a brand, ended in 2024. I guess what we're doing in its place at the moment is a much bigger focus on community resilience in the context of crisis, displacement and conflict. So we have some responsibilities at a regional level to support public mental health responses to situations, geopolitical situations, crisis events, and we're looking at the potential for a grant scheme to support that work. So that's what we're developing at this point in time as part of our grant agreement with the GLA.
Okay, so that's something that's sort of a new area that you're looking to look at, which still.
It's an area that we've had responsibilities around since coming out of the pandemic, because we had a particular role during the pandemic, and we were asked to maintain some crisis response and recovery capabilities within Thrive London. So it's a long-standing piece of work. What is changing is our approach, because of what we're understanding about people's needs and through community engagement, and the need to support more community-led initiatives that speak to these events and support people's mental health.
Okay. And Dr. Coffey, just on the new health inequality strategy, so you've mentioned the 250 opportunities for young people, and how what's in the plan in the implementation plan will impact men's mental health. Is there anything more to add in terms of the inequality strategy from your perspective? Sorry, microphone.
I've done this before. Right. So we're planning to also invest significant amounts of money in offering mental health first aid type training to mentors who work with young people in London. Secondly, obviously, we're supporting Thrive. Thirdly, we're doing a mental health programme in schools, and that is the 16 boroughs. And they're the key areas apart from our Larch work as well. A lot of the work that we've done in previous his implementation plans is ongoing. So, and I am a great fan of our work on healthy schools and healthy healthy early years, because that lays the kind of building blocks to promote good mental health, childhood resilience. And it's not just, and the key thing is not just to treat mental illness when it arises, but to make the interventions which keeps people healthy from their mental health approach, which is about resilience, about being able to cope with the stresses and strains of life without necessarily triggering into a mental health crisis. So that's the kind of work we do via a Healthy Schools programme, and also a Healthy Early Years as well, which of course is ongoing. Thank you.
Assembly Member Ahmed.
Thank you, Chair. Good afternoon, panel. My questions are to Billy and to Karen. So could you first give an overview of the NHS mental health services available in London for adult men? And within your answer, tell us whether they're meeting demand and what more funding is needed, please.
Hello, hi everybody. So thank you for that question. So I think it's important, similar to some of my colleagues that have already noted, that we have mental health provision for all people, and we recognise that men access it less, and I think we have to acknowledge that in this time. So there are a few things that we have. We have our talking therapies, which is really important for people to be able to access for anxiety and depression. And that can be accessed via GP, referral, primary care. We have the Child and Adolescent Mental Health CAMS service, which provides support for our children and young people. And we know that 50% of schools and colleges and education settings provide early intervention and prevention support. And we have the Adult Community Health Service, which provide care and support to those with serious mental illness. And we have a range of other crisis centres as well, which are commissioned. And I think it's important to note as well that we have universal coverage of mental health crisis line support where people need it. So there are a number of different access that men can also have to support their mental health and well-being. I don't know if you wish to add anything.
Yeah, I'd agree with all of that. And I'm a clinical psychiatrist, practicing psychiatrist, so I'm a doctor that specialises in the treatment of mental illness. It's always been the case in my career that mental health services have been underfunded. It's just kind of an accepted fact that we've had to adjust to. When you look at what the NHS spends on mental health services in London, you were able to get a sense, an average spend per head of the population through the integrated care systems. So we've got 5 integrated care systems within the NHS within London, and all of those spend approximately £200 per person on mental health care. But the English national average is £250 per person. So I believe that mental health services are underfunded in England, and particularly underfunded within London. So there is we know that there's still stigma around mental illness and treating mental illness, and we need to make sure that we properly invest in mental health care. There's also a lot of variation in service provision across London. So Karen's absolutely right. All of those services do exist across London, but the actual specification of them, whether or not they meet demand that's being referred into them, there's significant variation. And we know that for particular types of disorders like ADHD is really topical at the moment. There's a lot about that within the news. We've got really, really long waiting lists for assessment for treatment for ADHD within London, across England, but particularly in London at the moment. So I would say no, that we haven't got it quite right, and we would benefit from more investment. The other thing I wanted to say is that we've published a new mental health strategy for London just in May of this year. So it's the NHS London Mental Health Strategy, and it's a 10-year strategy where we're going to try and reduce the variation and invest further. And we want to see greater standardisation in how we're providing mental health services across the capital. So we're doing things like looking at a core offer for our community mental health services. So you're more likely to get the same type of service if you live in East London versus West London, for example. Sadly for men, so maybe let me flip it the other way. So treatment for mental illness is really effective, right? So if you have a mental illness, you're likely to get better if you have treatment, and men are as likely as women to get better from treatment. But men don't access treatment as much as women. So for the talking therapies that Karen was talking about, only about 1/3 of people that access NHS talking therapies are men. But if you're thinking about what Tom was saying about suicide, we know that middle-aged men are a particular area of concern when it comes to suicide, and the National Suicide Prevention Strategy has middle-aged men as a focus area. And treatment of mental illness is a modifiable risk factor for suicide, if you like. So if we're able to treat more men who have mental illness that are not currently accessing NHS services, hopefully we'll have a greater impact on suicide within the population. So I would like to see more men accessing NHS services. I would like to see more men accessing services earlier and having treatment for common mental disorders when things are milder, if you like, rather than illness progressing. We know that in our more severe services, people that treat our services that treat people that are more severely mentally ill, men are overrepresented there. which kind of suggests that they're presenting later. They only get treatment if they're in a crisis, if you like. So what's called our psychiatric intensive care units, so these are inpatient units within London where people are very, very mentally unwell and require intensive care. Over 70% of those people are men. So we haven't quite got the pathways right across London, and we need to correct that.
Thank you. Billy, you talked about waiting lists in a particular scenario, ADHD diagnosis. My question is more generally about waiting lists. So for many years now, we've had long waiting lists, not just for mental health, across the NHS, but we know this is very much in the public domain. Can you tell us what the current picture for waiting list times for mental health services in London is, and how damaging are those long waiting list times?
So I think we all acknowledge that there is a waiting list issue. We've all seen that across the NHS, and people are waiting much too long. We do know that some of the therapies that I talked about, if people were to access those, actually they can be seen, talking therapies, within 6 weeks. But not always people are accessing those. So I don't have the exact delays for mental health here, but we do know that people are waiting much, much too long. There is a focus of attention to reduce those waits, and as we've said, we've just published in just May the mental health strategy, and one of the priorities in that is to reduce the waiting times and to reduce the inequalities that we see in access across London, as outlined there, because it's really important to us to acknowledge that it's certain groups of men. We know that black men are more affected, we know that, and we know that they have disproportionately more greater impact as well. So focusing on those groups specifically, there are some great opportunities for us to do more for those men and that group through our strategy that we've developed.
Thank you. And I wonder, Chair, if it's okay to ask for Karen to send that information to the committee, if that's okay. Thank you. So, a very specific question now. NHS England data from 2025 shows that 1,840 patients in North Central ICB have been waiting for 78 weeks for community mental health services, but only 35 have waited this long in South West ICB. Can you explain the large disparity in waiting times within those areas and specifically across London?
So we've talked a bit about social determinants of health, haven't we? And we know that part of the variation that we see across London is because there's variation in social determinants of health. Poverty is strongly linked to mental ill health, and we would expect to see more referrals into mental health services where there's greater poverty. Personal finance, being in problem debt, having a forensic background, all of these things are going to increase people's chances of mental illness. So we would expect to see variation across the capital. I've already mentioned that there's variation in investment in mental health services, and we know that South West London, ICS, and did you say North East? North?
So it's North Central.
North Central, yeah. Invest different amounts per person into mental health services, and so you would expect a disparity in treatment there. In community mental health services across London, we've invested, the NHS has invested in community mental health services since 2019, and we have seen an increase in the numbers of men that are seen in community mental health services over that period, but absolutely accept that there are still unacceptable waits for men receiving treatment.
Billy, I'm so sorry. Would you mind bringing your microphone just a little bit closer to you? Thank you. Thanks very much.
Marina, can I just add to that? So, just to give you some kind of, like, as a South West Londoner, I've got, I'm really pleased where obviously I live. So there's for CMHT, there's 3 targets. There's emergency 24 hours, urgent 7 days, routine 28 days. So when you look at the figures, so therefore the focus tends to be on the urgents and the emergency presentations, and also people with a new presentation of psychosis, which has the early intervention service. And then the 28 days are often patients who are either less unwell or kind of a part of a system of follow-up, both with the assessment service and also their CMHT team. So when you look at those figures, South West London, I'm really pleased there's only 35 numbers, but in North Central, it could well be that those figures are all the ones waiting for routine, and it could be the fact that they're breaching the 28-day target, and they're waiting 68 days. So I'm not quite sure what the waiting time is, but it's probably in that third cohort of people who are waiting for a routine CMHT appointment. So just giving you some kind of how they segregate the waiting times within CMHTs.
That's really useful, thank you. And that requires a bit of a deep dive into those stats then and working out how that works. Thank you, Tom. So again, back to Karen and Billy. What action in the NHS in London what action is the NHS in London taking to ensure that mental health services are tailored towards men and to increase engagement with men who need that mental health support? So, what are we doing to reach men effectively?
So I'll make a start with that. So there's lots of initiatives. There's some specifics in certain areas that people are doing. So there's some great examples in community settings. For example, Bexley's Barbershop Project, which also support men's health. So trying to access men whilst they're a captive audience. And we know that often they will share things with maybe their barber and other people that they don't in other places. There are a number of different local community groups that are really doing some amazing stuff. And as we know, it's really important for us to reach men where they are. And there is a number of other projects similar across London as well. East London Foundation Mental Health also setting a pilot around the community centre as well in Tower Hamlets to provide 24/7 mental health services as well for prevention and risk of admission. So all of these are targeted people with mental health, and there are specifics for men. And I think we know we've got to do more, and that's the bit where we've talked about earlier about how do we make sure that things like in Bexley are spread across London so that actually we can have specific targets for men, specific areas for men to be able to go to and have access to support and know where to go. So there are a number of different local elements, and I think that it's important for us to sort of look at scaling them up. We talked already about the variation, and we recognise that, and I think those are the bits we've got to work on, and we know that we have to do better in making sure that men have access. So we have a group that we've just set up. They're advising the Mental Health Board, and they're particularly made up of men from Black and Asian backgrounds as well, so that we could take their live feedback so that we could further develop more services tailored to specifically to that group, which we know are more affected than others.
Thank you. I don't know if you heard the previous panel that was here, men with lived experience of mental health issues and services. And one of the things that came across, well, two things. First of all, there does seem to be this question of a postcode lottery, and I think, Billy, I'm really optimistic that the initiative you talked about earlier that may address that in future and standardise those services, because certainly one of our participants talked absolutely specifically about, I can have this service here, but literally, just across the borough border, that service isn't available. So one of the things that came across very clearly is that even in a difficult situation, in a crisis, patients are having to navigate and advocate for themselves. How can this be addressed?
So, I think we acknowledge that there's variation. We've really got to reduce that. So one of the things, and I'm happy to share with you the strategy that we've developed that was published in May, is really to do exactly as you said, to provide equitable and timely access and support to intervention across London, and making that much more transparent and joined up. And that's one of the sort of strategic outcomes that we have. So we're still at early stages. We've just published that in May, and therefore we will be looking at the data across London and making sure that we can try and eliminate some of those variations. And that's the work we've still got to do, and that's one of the aims that we have as part of the strategy. don't know if you want to add anything.
I was just going to say that when somebody is in a mental health crisis, it can be difficult to access services. Absolutely accept that, and we want to make sure that people are supported at the most difficult time when it can be more difficult for them to make decisions and to advocate for themselves. So, for patients, people who we know well that are already in our services, we try to identify where people have those additional needs and give them support, so that we might buddy them up with care coordinators or key workers who they can build a trusting relationship with, who can help them navigate those services. But we do need to make services more understandable as well. In my local services, I work in South West London, like Tom, and in my local services, I'm often trying to encourage us to be able to simply articulate what our clinical model and service model looks like. Because if we can't describe it as professionals, if it's not easy for Tom and I to be able to talk about it in a meaningful way, what chance does the public have? So we need to be able to make things simple too. And lastly, I would just say about digital. We've got to we've talked a little bit about productivity and demand, and we expect that demand for mental health services is going to continue to grow, and that's right. We want more people to access services, so we need to be able to do more work. But in order to achieve that, if our resources don't grow, we've got to get more efficient. And children and young people are more digitally literate than older people. We need to make take advantage of the digital offer. People don't always realise that mental health services can be delivered digitally in an effective way. So, for example, during the COVID pandemic, a lot of us, myself included, had to move some of our clinical practice away from face-to-face appointments to doing video conferencing and online. In my organisation, when we looked at treatment for common mental disorders, so that I'm talking about anxiety and depression of mild to moderate severity, we had pretty good evidence that the treatment that was delivered over video conferencing was as effective as face-to-face. And that can bring productivity benefits. Running clinics, having face-to-face clinics is work and has demand. We can be more efficient delivering services digitally. It's not for everybody, but it will have a role in the NHS in the future, I think.
And can I just add, there also is two universal London-wide kind of crisis line services which can also direct you to the right place. The 111 service now is a Press 2, and that's the mental health crisis line. So anywhere in London, if you want to almost find out, where is the best place for me to go, and often it's not the patient, but it's the carer looking after the patient in crisis needs to do that. Also, I think, and Karen will correct me here, is that every single trust in London, mental health trust, now is a crisis line. And therefore you can ring that crisis line. There's one at Springfield, there's one and at the Maudsley, etc. And that will also do an assessment and might say, you don't need to be seen today, but we can sort you out to be seen the following day. And that can get around that geographical postcode sometimes, whereby people don't know what to do. They go to the GP, they're referred on, and they go into a vacuum. Whilst direct contact to those two services, those two crisis intervention services, can get around a bit of that postcode lottery, and also the knowledge of where the services are, because we can't all know where they are, but 111 and the crisis line does.
Can I then challenge you on that, Tom? So one of our participants in the earlier panel actually gave a description of what had happened to him when on a Saturday afternoon he went to A&E in a mental health crisis, and I don't know how long he waited, but was eventually told that he needed to go home and that his information would be passed to his GP on Monday morning. What went wrong there?
It's very hard for me to comment on individual cases, but I just giving my experience of what happens, let's say, in my local patch, often patients will be in a crisis and they don't know where to go. So you go where the lights are on, A&E. So they'll turn up to A&E and they will have got an assessment initially by a triage nurse, and then most mental health trusts have a liaison service, I'm waiting for my colleagues to nod here, and that liaison service will either manage the patient or take the assessment by the triage and say, this person's crisis doesn't require an immediate intervention now on Saturday, but they do need to have an urgent follow-up by their GP. And therefore, I will get an email which gets my desk on 8:30 Monday morning, and then I will ring the patient. That's what should happen. I'll say, oh, Mr. Jones, I see you're in A&E. They felt you didn't need an intervention there and then, but can I bring you in to work out what we can do? So my sense is the communication that our patient had about that pathway was meant to working wasn't very clear. And all they felt was they were dumped and palmed off. Right, but whilst if you ask the nurses and the team, they might say, oh, we did an assessment and we put them to the right place. So, so I do get many patients who go to A&E and come and see me on a Monday, and that is mostly appropriate. I mean, I don't know, Karen and Billy can comment.
Yeah, I mean, again, can't comment on a precise issue, but yeah, absolutely. We do know that we're doing more work around sort of the crisis part of the mental health pathway. We recognise that, and I think it's important that, like Tom said, that in that the health providers would have decided what's the best pathway for that individual at that time. And I think it's important as well how we maybe communicate that better to those individuals and with clarity. And there may be some more work for us to think about that, so that they're not left feeling that was not necessarily supportive of their condition. I don't know if you want to add anything.
I think the only other thing I would say is that we want people. Different people experience mental health crisis in different ways and require different things in crisis. So it's A&E can be the right place for people if they've, for example, taken an overdose of some medication. They actually might need some physical treatment as part of their mental health crisis, and that's why it's so important that when we're developing services, that we do it in partnership with patients and the community and people that have used mental health services, because I think it's easy to assume that A&E isn't the right place, and it's not always the right place, but sometimes it is. If people, physical and mental health are not always separate, and I know there's a group of people that use mental health services that don't want their physical health needs to be neglected if they're in a crisis. At the same time, A&Es are busy, they're noisy, they've got electric lights, often no natural light. It's not the place that you want to be if you're in a mental health crisis, and so we absolutely need alternatives to A&E to support people too. So all areas of London do need a range of resources, absolutely.
Thank you. My final question is about social prescribing. I've worked in the field of social prescribing, actually when it was a new thing a few years ago. Can you tell us about the role of social prescribing and what role it should play in mental health, and how patients can best access those services?
So, yeah, I think social prescribing has a huge part to play, and we know as we move into the new world of what the health service will look like and we give care closer to home, these things are going to be important. So if somebody is feeling unwell or having some anxiety or depression, then accessing other ways to improve their health and well-being is really important. So I think there's more we could do with social prescribing. There's definitely much more we could think about how to access that. And we've got some really great social prescribers out there who are doing a really good piece of work, but it goes back to the variation, and part of the strategy is how we can make sure that people across London can access that. Because actually, if you prescribe somebody a gym or something else that's different, it might help with their mental health and well-being. So it's going to play a huge part, and I think we can see that improve over time.
Are social prescribers trained in mental health? And if not, should they be?
I don't know if all social prescribers are trained in mental health. I do know, so I've referred in my own clinical practice, referred patients to social prescribing, and I think the important thing is to have a degree of mental health literacy, so to be able to understand what the needs of people with mental illness are. when you treat a mental illness, it's really important that you think about the whole person. And there's the physical medication treatments that we might give, there's the psychological treatments that we might give, but the social circumstances of the individual are so important to that individual's recovery. And if you're thinking about older men, for example, and the isolation that they might experience in the later stages of life, dealing with that isolation can be a core component of the treatment package. And so social prescribers are essential partners, I would say. Yeah.
Thank you, and thank you, Chair, for your forbearance. I said it was my last question and then asked another one straight afterwards.
Okay. And just to comment on that is that, so social prescribing is obviously linked to the GP contract, so that's where they're 99% delivered, and they've got literacy in mental health issues, but not training. There's a new member of the workforce which came out 2 years ago called a primary care mental health worker, who are now also linked to the social prescribing service in general practice. They are mental health trained, and they look after patients who've got mental health diagnoses and have social needs. And they're the ones now we tend to use much more for patients with an ongoing social and mental health need. So it's the primary care mental health worker.
Thanks. Assembly Member Wilson.
Thank you, Chair. My question kind of builds on some of what you've discussed, Karen and Billy, in regards to some of Assembly Member Ahmed's questions. But I think what we've seen, and we can see the figures, and you've discussed the very clear imbalance between suicide and male suicide being persistently and significantly greater prevalence than amongst females, and yet the referrals to various different treatments, the reverse being the case. And in particular, the figures we have here in front of us for talking therapy show well over twice as many women being referred in the last year's figures compared to men. So we understand the what, and that's happened. So really want to sort of move on to more sort of the why is that happening, what's holding back men from either being referred or seeking help, and then the how we can improve on that and try and redress that balance, please.
So I would start by just emphasising the role of stigma. Yeah, I think that it's over the course of my career, I think it's been great to see that people are talking about mental illness more in society. Right, we see people discussing it more on social media. There's more articles in the news about mental health. So that is great, but the job's not done. And if you look at one way of interpreting the figures around access to mental health services, is that we know that there are different gender norms about what's acceptable when discussing one's health in general, but in particular one's mental health. There's still stigma attached to suicide, deaths by suicide, families that have been affected by suicide. So there's more work to be done. Now, we as the NHS can make an impact in that, and we work with our local communities. It's really important that we work in partnership with the VCSE sector and others within our community in order to try to tackle some of that stigma, but we can't do it on our own. And so the NHS is really interested in working with other partners, including local government, in order to try and tackle that stigma head on. However, we also do need to take responsibility for reaching out to men ourselves. And the awareness raising campaigns that we've been doing across London have tried to tackle that in the past. Our 10-year strategy going forward, there's a big piece of work in there around prevention as well. And so, Karen was giving you some examples of local projects that are done in different parts of London. But if we can get men talking more about looking after their mental health before they become unwell, that will help too, I would say.
If I can just add, yeah, I agree with everything my colleague said. I think we also have to acknowledge there's specific groups, and we look at we know black mental health, black men's mental health is far more impacted, but yet still, and there is stigma within those communities. And so us reaching into those communities, really understanding and trying to move away from what is accepted in certain communities for men not to access mental health, I think it's really important. That's why we've set up the group to have that advisory around specific groups that we recognise are more impacted than others. But I think there is work for us all to do in partnership to reduce that stigma and enable men to talk about their mental health. And I do think the example I gave earlier, like the barbershop, places that people have, I think will really help if we can scale that up and have more access for people to be able to make it normal to talk about this as well, will help.
May I just build on that point? That's important. So the other point that I guess we've not been explicit about is trust. We know that members of the black community, black men, don't always trust the NHS. So if you look, one of the things that I have to do from time to time as a psychiatrist is to use the Mental Health Act in order to bring people into hospital for assessment and treatment against their will. So we know that members of the black community don't always trust our institutions within society, don't trust the police, don't trust the NHS. And when we have those disparities in how we use the Mental Health Act, so we know that if you're a black man, well, if you're black, you're 3 to 4 times more likely to be detained under the Mental Health Act within hospital for assessment or treatment, and you're 8 to 10 times more likely to be discharged from hospital if you've been detained on something called a community treatment order that compels you to continue to take your treatment out in the community. So you're 8 to 10 times more likely to be on that if you're black. So these are really stark figures, and there's something about all of our institutions, how we work together within London to address those disparities. And until we fully address those disparities, there'll always be an issue of trust, I think, between us as an institution and the black community. Now, a big opportunity that we've got as a society to try to address that is through the new Mental Health Act. And we're expecting the government to be working on that in this Parliament. But I really want to see that having a meaningful impact on how we work with the black community.
Alex, can I just add something there? And I suppose this is the area that Sadiq feels most comfortable in. That's the reason he came out very much about his own mental health difficulties was he felt that by talking about it, he could make other men of colour to say, I've got those difficulties as well. I need to talk about them. And secondly, in fact, the IAP services, which is these talk therapy services, you can actually self-refer to them. You don't have to come to the GP. And in fact, but a lot of people don't realise that. People think, I've got to see my GP, I can't get an appointment, it's embarrassing. But you can actually self-refer. And during the pandemic especially, Sadiq was putting out messages, just ring this number, you can see a therapist yourself. And we have invested, I think, 580,000 in community organisations because whilst many groups don't trust the NHS, they will trust their own local churches, the local youth groups, the local community organisations by funding them and making them be the voice of saying, if you're not feeling great mental health-wise, please access services. That's a much more trusted message. And that's where I think Sadiq feels that his work with Thrive, the voluntary sector, his own personal statement, can reduce that stigma that you were talking about, the discrepancy, because otherwise, if we just do it the same way, we're going to get the same results.
I've actually got a question really to our officers rather than to the panel, which is based on, or picking up on a point that, Tom, you made in your kind of introductory piece about the fact that Sadiq has done mental health first aid training. Is that something that could be made available to at least members of this committee or the Assembly members more widely?
Enables you to deal with your colleagues and friends and yourself with mental health difficulties, because so many times the reason we did it was every single workplace has got someone who's St. John's first aid trained, right? But you're much more likely to have a mental health crisis at work than a physical crisis. So having colleagues who are mental health first aid trained is much more useful for your colleagues, your family and your friends, because often they turn to a friend with a mental health difficulty. If they break their leg, they're not going to go to you, they're going to come to me. But if they've got a mental health difficulty, they might turn to you, and you having the skills for assessment and just knowing what to do is phenomenally useful.
Thank you. That was all that. Yeah, perfect. Assembly Member Boff.
You've all been very convincing about the role that you provided and the challenges you're trying to address, but it's somewhat contradictory to the experiences we've heard from the people we've talked to today and on other days. We heard that the training of GPs on mental health issues was inadequate, and I think I asked a question in the previous panel. Would you say it's a minority of GPs had inadequate training, or is the majority? And they said the majority had inadequate training. And I do understand you can't train every GP to be a specialist in that work. I get that. We have this argument when we're talking about policing. You would love every police officer to be trained with every element of the law, but you're not going to get that, because otherwise they'd never leave training. And I understand that we can't make every GP a specialist, but should we be looking at the signposting that is taking place from GPs and some better training about identifying those mental health issues at an early stage? We also heard evidence that they were very willing to give drugs, and as Assembly Member Ahmed said earlier, very willing to give drugs, completely ill-equipped to give social prescribing. Do you recognise that as an issue, Ms. Bonner?
We recognise there is more to be done, and that lived experience is really important. And I recognise that, like GPs are, and obviously Tom can speak a bit more to that, as a practicing GP, are trained as a generalist, and they do their best to try and access services, and they have got the means to signpost. And I think it's important for us to recognise that that they are equipped with the right information to signpost people to the right, because as you rightly pointed out, they may not be fully trained in all of those elements as a general practitioner, and Tom may be better placed to say what that means in practice. And there is so much more for us to do. And I also think it's important that we remind people of what they can access. And like we said, there are helplines, there are talking therapies, there are other means that they can get direct access to the mental health provision that they seek, and ensuring that more people access that is something that we really need to target and make sure that we do more of to communicate that to the public.
Yeah, so every GP now does the MRC GP, a professional exam, which is the membership of the Royal College of General Practice. In its curriculum, which you have to follow, have to be signed off for, and you're examined on, is mental health training. So every single GP presently trained is trained in mental health. The mental health element of the training is kind of structured in a number of ways. First of all, there is just the assessment process. Can you do a good mental health exam? Whereby what you're trying to make sure, have they got a mild or moderate illness which can be managed within general practice, or a more serious illness which just requires the specialists like Billy and Karen and colleagues to look after. And then also what you really need to know as well is what is available in your area. Because there's no good saying, yeah, you've got a mild to moderate mental health illness and I can treat you with medicines or with non-medical interventions. You need to know what is around you. And therefore, most GPs, I'd say 90% of GPs have got social prescribing attached to their practice. But also the other allied health services that we all have, which is our IAP services, the improving access to psychological therapies. Every single practice in London has access to that service. That is designed, that divided into kind of tier 2 and tier 3 type services, whereby people are referred in for an assessment. They might have a tier 2 service, which is a less intense group service or a guided service, or a tier 3, which is a one-to-one service. So every GP has access to that, and anybody with mild anxiety or depression is eligible for that via a GP referral, and in fact, via a self-referral. So I think you will find that there's GPs of different experience and qualifications in mental health. I did a mental health psychiatry job for 6 months. So my level of training is a bit greater than the average GP, but every single GP does have the basic training required to pass the MRC GP.
I'm sure you do this in the NHS, but I think you need to survey the patients. I really, satisfaction survey of the patients, because what we've heard is some significant failings. Admittedly, in the past, you may be working on them now, but we've certainly identified that. I was unaware of, Ms. Bonner, I was unaware of the crisis line. I didn't know anything about it. How is that being promoted?
So, as Tom's already alluded to, most GPs will know what advice lines are out there. There is, it's communicated via NHS communication, the NHS app, etc. So I think it's important for people to know that there are alternatives as well. And I think it's important, if we're not getting it right for people, we do canvass people, by the way, we do ask for their opinions and we do understand their feedback. But the advice line provides advice to people as they need it. And if it is that people aren't accessing it, we just need to do more to make sure it's communicated. We do communicate it widely, but clearly there's always more that we could do.
I don't think it's wide enough, because I challenged our earlier group to say, what would you do now? And none of them said, I'd pick up the phone and ring the crisis line. Dr. Burley.
111, do you think? Because 111, I think, is it 2 years ago it had the mental health? I don't know quite when it was started.
Yeah, it's a few years, and you're right, it's 111 and then #2, then you can get that mental health support as well, because that is being widely advertised as well for people. Yeah. So, but
yeah, I was going to agree with you. I mean, if you think about how commonly 999 is known about, everybody knows to call 999 in emergency, and so until we've got to the point in society where it's just common knowledge that you call 111 and you press 2 if you're in a mental health crisis, we haven't done our job. So again, we need to work with partners in order to raise awareness about that. We had at my trust, we have a board meeting in public every 2 months, and we start our board meeting with a patient story. So one of our patients who've used our services will come and tell us about their experience from a different service. And there was a story 6 months ago or so where a patient had presented to mental health services for the first time in some years, and he'd gone to A&E. And he was telling us the story, and we did support him and got him into supported housing and provided him with some mental health services. But it became apparent during his story that although he was homeless and living in a park, he had a mobile phone. But he didn't know that he could get help through his mobile phone. He didn't know that he could call 111 and press 2. And so there's still something that we're not getting right. He didn't need to go to A&E to get to us.
Yeah. I mean, you'll expect me to say this, Dr. Coffey, but it would be lovely to see that information advertised on the tube.
I did want you to hear this answer. And so, I take the point whereby, those important messages that and I might talk to our NHS partners if they wanted to use the tube as a way of penetrating London, to say, if you're in a mental health crisis, please ring 111 #2.
I would really love to see a single message anywhere on the transport network that gave people a pointer when they're in crisis.
Okay.
But there isn't one anywhere
Leave
on
them with
the
me.
Entire tube network.
Okay, I will take that back, because Sadiq meets the regional director on a regular basis, and I will promise to put that on the agenda for our next meeting. Thank you.
Thank you, Chair.
We really welcome that, Tom, so thank you. Dan, I wanted to come back to you, if that's okay, because now I didn't want to step on any toes, because I knew Right to Thrive questions were coming up, but now they're over. I'm going to circle us back, if that's okay. The 2 projects you named to me earlier, I struggled to find the information online. I know you said they were published, and I went back again. What was the Bangladeshi forum? I thought that was a forum open to all, but the suggestion was it was a men's forum. Do you know what year that was in?
I don't know the year. I can obviously find that out and share that with the Assembly. The information should all be on our website.
Yeah, it references some projects. It doesn't reference any Bangladeshi.
2022.
2022. And what was that one called? Sorry, if you have it.
Or the Bangladeshi Mental Health Forum one-to-one culture-appropriate mental health wellbeing signposting service.
Yes, that's the one that I thought it was. It doesn't. So it says it was for individuals and families. It doesn't say it was a men's service.
I mean, I understand it. There was a men's funded service via that organisation, and that's the year I've got of the funding details. But we can kind of clarify that. But I had the same information as Dan had from a different source.
Okay. No, it would be good because on the website it doesn't suggest that may be the case. And was that also a 2022 project for the rugby? Dan?
Again, I don't have the information to hand, but I will find out and share that with the Assembly.
Please, I would say, I think, given that we're doing this session, it would be good to come with those case studies because I think that's a good story to tell. If my line of questioning now is going to be what more can you do, it would be nice to know what you have done in more detail. But leaving that aside, I think looking at the Right to Thrive project and funding in general, will you look at how we can do more funding, more commissioning for men's mental health services? And especially I'm looking through the list of what we funded before. I'm thinking one of the target groups we surely want to reach is middle-aged men. And when I was looking through the list of projects funded compared to that target group, I'm not going to stereotype, but I'm thinking perhaps rugby isn't the best way to target middle-aged men. And also that project, I believe, was around intro into rugby as well. So is there something we can look around middle-aged men and perhaps, obviously understanding there is intersectionality in all of this, but men as a specific group, I think, we've seen aren't accessing those talking therapies. Can we look at how we can get them into services through Thrive London?
Yes, we can absolutely look at that. I guess what I'd say is we establish the criteria, the specifications for inviting quotes from community partners for projects. What we can do is absolutely make it clearer that we're welcoming projects that particularly support men.
That would be good because I think this is probably a different issue to what we normally talk about in society. And from the way in which the Right to Thrive grant system is written up, if I was a men's group, I probably would think that I was excluded from that. It doesn't sound as though it would be for that my type of group. Say if I ran Andy's Man's Club or one of the other groups we've spoken to. So I think that would be good if we could look into that. And Karen, just to come back to you, and Billy, you were raising about the sections under the Mental Health Act and bringing down the disparity. And I just wanted to clarify that you meant perhaps in the early stages that you wanted, because what I wouldn't want to see is people reaching crisis point and you're thinking, well, we don't want it to the figures to be skewed, so we won't section this person, but they really need that help because as we've talked about before, the problem is not accessing it until the fire, until you're in real crisis. So just to clarify, did we mean sorting it before that level? Because I wouldn't want to see anyone being scared of the figures looking bad at this point and so not giving people the help they actually really unfortunately need then.
Yes, absolutely. I mean, I want to make sure that everybody that needs mental health treatment gets it, whatever stage of the journey of their mental illness that they're on. And absolutely, we want to support everybody in crisis. And we want to make sure that people are accessing treatment earlier because mental illness kills, and it causes suffering to individuals and to families and to society. And there is good evidence that the earlier that we treat it, the better. So if we can have a more trusting relationship with our black community, and we can get them into services, into our talking therapy services, into our community mental health services before they require detention under the Mental Health Act, that's got to be a good thing.
And we just can. Sorry, Karen, you go first.
That's okay. So, yeah, I agree with everything been said. I think it's also important to note that there is a correlation with some other substance uses as well that we're also put in part of our strategy to look at. So we know that men are more likely as women to become dependent on alcohol and report frequent use, etc. So all of those things are flags that we are looking at as part of the strategy that we've got to hopefully pick people up much, much earlier in their pathway before they get to that crisis as well.
What I was going to say was that it might be maybe part of your conclusions of your report. I mean, echoing your point is that what we want, and Alex was saying this, so you want the preventative services to have probably more men than women, because that reflects the present kind of mental illness and severity of mental illness. And the talking therapies from each borough, I know, has a yearly improvement action plan to say, well, where are we missing the bits? I know, in fact, often they say, you know, you did a report years ago looking at LGBT mental health. And I used it with all the boroughs saying, you know, this is where the big need is, and they devised action plans to respond to that. So if there is a men's report, you're going to come out and say, you know, this is where the big gap is, I'd want to be sharing it on your behalf with all the talk therapists and say, your action plan for your 26-27 needs to say, address this disparity, might be something you want to consider recommending. And also, in my kind of very quick research, so it's 2021 was the rugby club project. It's called Expanding Horizons Community Rugby for Young Black Men in 2021, Hammersmith and Fulham.
Thank you. Thank you very much. That's very helpful. And actually, a really good segue. You talked about using our report to promote men's mental health. A report, I think that, or strategy, I should say, that I think might just somewhat get more media coverage than ours is the government's men's health strategy, which is due to come out. And obviously, I want to start with you, Billy and Karen. You've just talked about the mental health strategy for London. What do you think you would want to see or will be feeding into that men's health strategy that the government's working on?
Yeah, I'll make a start. So it's a really important piece of work, and I would absolutely like to see a focus on racial disparities, because we know that that is a problem, and we know that in targeting those groups, then hopefully we'll have better outcomes. So for me, it would absolutely be racial disparities.
I completely agree with that. I'm really pleased that you talked about intersectionality. We know that LGBT people are still more likely to experience mental illness, and so there should be a focus on LGBT people within the men's mental health strategy. We talked a little bit today, haven't we, about comorbid physical and mental health issues. So tackling the physical health issues of people with mental illness is equally important. So you may or may not know that if you have a serious mental illness, and by serious mental illness, I'm talking about people with diagnoses like schizophrenia, bipolar disorder, major depression. At the moment, your average life expectancy in England is 15 to 20 years younger than the general population. Imagine that. And there's lots of reasons for that, and we've talked a little bit about access, we've talked about comorbidity. A few years ago, 2021, I had a look at the data in southwest London. We've got a way of registering people with a diagnosis of serious mental illness and looking at their data and looking at the other comorbid illnesses that they have. And I knew that there was comorbidity between diabetes and serious mental illness, but I didn't realise in southwest London at that time, over 50% of people with serious mental illness also had a diagnosis of diabetes. And we know if you have a serious mental illness, you may be less likely to engage with physical health services, treatment, etc. Smoking cessation is really important. Alcohol and drug misuse, as Karen has said. So we absolutely need to make sure that mental health is not just thought about on its own, and we're treating the whole person. Suicide, middle-aged men, as I said earlier, is a priority focus area within the National Suicide Prevention Strategy, but still the biggest killer of men under 50. So we absolutely need to have a focus on preventing suicide and really emphasising that suicide is a health problem, and if you treat mental illness, that we can prevent suicides. That needs to be in there. And then I've talked about stigma a lot today, but again, we need to make sure that there's a focus on addressing stigma, because unless we address stigma and trust, we're not going to be able to deal with the men's health issues. Yeah.
Thanks. Dan, what would you like to see in that strategy?
Gosh, well, I feel Karen and Billy have very comprehensively answered that question. The thing I would add, I agree with everything that they've said. The thing I would add is that we know that men are less likely to seek help for their mental health. And so there's a particular need to focus on help-seeking behaviour. How do we work with men to encourage them to seek help when issues arise? And a general point around co-development, co-design with men and different groups of men is very much needed, I guess, because the challenges are quite complex and need to be kind of understood and unpicked.
Thank you. And Tom...
Sorry, do you mind if I interrupt? It's very small. One of our previous guests talked about co-production. Is that something that you support as well, of services? Sorry, it's just relevant to that.
Yes, I think co-production is very important for all aspects of mental health. Yeah.
That's okay. And Tom, obviously, your answer to that question is whatever we think is what you think should be.
As ever. But one I would say, I'll take the point that Alex had said, about stigma, and you've got to address the balance whereby we've got the services, but are being almost used by the people that we shouldn't be directing our services at, and that's because of stigma. So I would really focus on that and whatever else you tell me on the 16th of July. Thank you.
No, thank you very much. And thank you to everybody here on this panel for being here today and giving up your time this afternoon. We really, really appreciate it. And it is very helpful going into our report. So with that, we've just got a couple of things to do. So it'll be really quickly, but if you want to start packing up, absolutely go for it. But we will be finished in a second as well. So thank you very much to all our guests for the contributions. Can we note the agenda report and today's discussion? Can we delegate authority to me as chair in consultation with party group leads to agree any output from the discussion? Agreed. Thank you. And we will probably have a conversation sooner about that than we thought. The Health Committee work programme, can we note the committee's programme and the additional activity since our last meeting of the informal roundtable hosted by Mind on the 26th of June 2025? Thank you. The date of the next meeting will be the 10th of September 2025 at 10 a.m. in the chamber. As there is no other urgent business, so I therefore can declare this meeting closed.
This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.